Welcome to this board review on managing bipolar disorder. This video is brought to you by Roadmap to Residency. Bipolar questions are less about memorizing every drug and more about reading the stem for the diagnosis, naming the phase of illness, and then choosing care that is both correct and safe for that specific patient. Our goal today is not to reteach all of psychiatry. It is to show you how these question stems are built and how to attack them. Make sure you are also working through your question bank and a solid psychiatry review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is our game plan. First, we will learn to pick the right mood stabilizer straight from the clues in a question stem, rather than reciting a textbook. Second, we will recognize and manage acute mania, and then separate that from choosing long-term maintenance therapy. Third, we will nail down exactly when the correct answer on the exam is to consult psychiatry. Throughout, we will walk through practice questions and explain why each choice is right or wrong. Keep your favorite psychiatry review resource open so you can read the fuller background on anything we move through quickly. Strategy 1 is to read the stem for the trigger words before you look at the answers. The exam hides the diagnosis in a handful of phrases: elevated or irritable mood, a decreased need for sleep, grandiosity, rapid speech, and risky spending or sexual behavior all point toward mania. A distinct period lasting at least 1 week, or any length if the patient needs hospitalization, confirms a manic episode. Once you have the diagnosis, immediately ask what phase you are in. Acute mania, acute bipolar depression, and maintenance are 3 different questions with 3 different best answers, and the same patient can generate all 3. Naming the phase tells you which rule to apply, so it is the most valuable habit you can build. Strategy 2 is the mood stabilizer selection mindset. Let the feature in the stem pick the drug. Lithium is the classic answer for classic bipolar disorder, and it is the agent with the strongest evidence for reducing suicide risk. Valproate is favored when the stem emphasizes mixed features or rapid cycling. Lamotrigine is your maintenance answer aimed at preventing the depressive pole. Just as important, screen before you start. Valproate and Carbamazepine are wrong in a person who could become pregnant without reliable contraception because of the risk of birth defects. Lithium is risky in kidney disease. When a stem mentions a young woman, thyroid disease, or kidney function, it is quietly testing whether you check safety before you prescribe. Baseline testing and monitoring is a favorite theme. Before starting lithium, the correct next step is often to check kidney function, thyroid function, a pregnancy test, and an electrocardiogram in the appropriate patient. If an answer starts lithium with no workup in a stem full of renal or thyroid clues, that is the trap. Next, know the toxicity triggers. Lithium has a narrow safety window, and dehydration, kidney injury, and certain medicines push levels up quickly. Watch for a nonsteroidal anti-inflammatory drug, a thiazide diuretic, or an angiotensin-converting enzyme inhibitor added to a previously stable patient. Tremor, confusion, and an unsteady gait in that setting is lithium toxicity until proven otherwise. Finally, beware the do-nothing trap, where a calm-sounding choice continues the drug in a clearly toxic patient. On this exam, missing toxicity is as wrong as overtreating. Let us work a question. A 22-year-old man is brought in by his family after roughly 4 days of almost no sleep. He has been talking rapidly, spending large sums of money, and launching several new business plans. He is irritable and pacing. His vital signs are stable, and his physical examination and laboratory workup are unremarkable. The question asks for the most appropriate next step in management. Take a moment to name the phase and pick your answer before we walk through it together. Let us reason through it. 4 days of little sleep, rapid speech, grandiose plans, overspending, and irritability is a manic episode, and he is clearly impaired, so he needs treatment now. This is acute mania. The rule for acute mania is to start a mood stabilizer such as lithium or valproate, or an antipsychotic, and to stop any antidepressant that could be fueling the episode. So the best answer is to start a mood stabilizer or an antipsychotic. Now eliminate the rest. An antidepressant alone can worsen mania and is a classic trap. Reassurance and follow-up next month ignores a dangerous, impairing episode. Routine brain imaging is not required when the history is a clear manic episode and the workup is already normal. The answer is to start a mood stabilizer or an antipsychotic. Here is a maintenance question. A 30-year-old woman with bipolar disorder has recovered from a manic episode that was treated in the hospital. Over the past 2 years, her episodes have been mostly depressive. She plans to stay on treatment long-term, and her kidney and thyroid function are normal. The question asks for the most appropriate medication for maintenance. Notice how the stem is steering you with the words mostly depressive and long-term. Pick your answer, then we will walk through it. Let us match the drug to the pattern. The stem tells you her episodes are mostly depressive and that she needs long-term maintenance. That combination points you toward a medicine that prevents the depressive pole. Lamotrigine is the maintenance agent best suited to protecting against bipolar depression, so it is the answer. Now clear the distractors. An antidepressant alone risks a switch into mania and is not appropriate maintenance monotherapy in bipolar disorder. A short benzodiazepine course treats agitation briefly and does nothing for long-term prevention. Stopping all medication invites relapse in someone with recurrent episodes. The answer is Lamotrigine. Let us talk about when the correct answer is to consult psychiatry. Certain stems are built to escalate. Active suicidal or homicidal thinking, psychotic features, pregnancy, and failure to respond to first-line treatment all raise the stakes. When consulting psychiatry appears among the choices in those settings, it is usually correct rather than a distractor. But there is a catch that the exam loves. Consulting is right, yet you still stabilize and keep the patient safe first. Ensure safety, address dangerous agitation, and start clearly indicated treatment before you hand off. The strongest answer usually does the immediate safe action and then involves psychiatry, rather than referring while ignoring an urgent need. Here is a high-yield safety question. A 28-year-old woman with bipolar disorder is newly pregnant. She has been stable for about a year on Valproate, and she asks how to manage her medication safely during the pregnancy. She currently has no manic or depressive symptoms. The question asks for the most appropriate next step. Think about what makes Valproate dangerous here, then choose your answer before the walkthrough. Let us reason it out. A pregnant patient on Valproate is a safety problem because Valproate carries a high risk of birth defects. This is exactly the kind of stem that wants a coordinated plan rather than a solo decision. So the appropriate step is to consult psychiatry to review safer options and adjust her therapy. That is the answer. Now the distractors. Continuing Valproate unchanged ignores a well-known teratogen. Stopping all treatment risks a dangerous relapse during pregnancy. Adding an antidepressant does not address the real problem and risks a manic switch. The answer is to consult psychiatry. Here is a pearl that ties everything together, the phase then safety filter. For every bipolar question, first name the phase. Decide whether you are in acute mania, acute bipolar depression, or maintenance. That single decision eliminates most answer choices right away because a maintenance drug is wrong in acute mania and an acute agent is wrong for long-term prevention. Then run the safety filter over whatever survives. Ask about pregnancy, kidney function, thyroid disease, and dangerous drug interactions. The choice that is both correct for the phase and safe for this specific patient is your answer. When two drugs both look reasonable, safety is almost always what breaks the tie. Let us bring it home. Drill these patterns in your question bank until naming the phase and selecting the drug feel automatic. Read every explanation, even for the questions you got right, and review the psychiatry chapter in a trusted board review resource so the underlying reasoning is solid. Keep practicing under timed conditions so this thinking feels natural on test day. Visit www.roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped you, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.